Welcome to St. Luke's Health Now, a show dedicated to giving you the most up-to-date information on innovative medicine. I'm your host, Ashley Russo, and we have a unique show for you this evening. We're talking innovations in heart care at St. Luke's University Health Network. Today, we will be joined by a talented panel of experts in the field. Stay tuned. This is St. Luke's Health Now. Coming up on this episode of Health Now, an in-depth look at innovations in heart care at St. Luke's University Health Network. Stay tuned. Thanks for joining us. Let's get started. We have an accomplished panel of guests joining us tonight. Up first, we have Dr. Michael McCulloch, a board-certified cardiologist specializing in general cardiology, heart failure, and cardio-oncology. As Director of Cardio-Oncology Program at St. Luke's, Dr. McCulloch cares for patients with a current or prior cancer diagnosis who have had cardiovascular symptoms, cardiovascular disease, or exposure to chemotherapy. Dr. McCulloch received his medical degree at the University of Virginia School of Medicine. He completed fellowships in cardiology and advanced heart failure at the Cleveland Clinic. Dr. McCulloch, thank you so much for being here.
Pleasure to be here.
Tell us a little bit about what cardiovascular disease is and how did you become interested in this field?
Cardiovascular disease is essentially disease of the heart and the vessels which carry blood around the body. I became interested in cardiovascular disease because it's a really common problem and there's just a tremendous opportunity to help people and improve the quality of their life.
Sounds very rewarding. Thanks for being here. Joining our panel next is Dr. Chris Sarnoski, the Director of Interventional Cardiology and the Structural Heart Disease Program at St. Luke's. Dr. Sarnoski received his medical degree from Philadelphia College of Osteopathic Medicine and completed fellowships at Maine Medical Center and the University of Vermont School of Medicine. Thanks for being here, Dr. Sarnoski.
Thank you for having me.
What is involved in the field of interventional cardiology? How is that different, and what gives you the most satisfaction with what you do?
So interventional cardiology deals with trying to fix things that are broken with the heart through catheter-based therapy. So we typically will put a small tube about the size of a coffee stirrer in a wrist, or some of our bigger procedures will use a slightly larger tube and put that and use that for the leg. And what we typically do on a day-to-day basis is treat heart attacks, treat patients with chest pain by delivering stents through these catheters. The field of structural heart deals with other non-artery related repairs of the heart. That may include a valve replacement, a valve repair such as the mitral valve, as well as plugging holes in the heart, things called like a atrial septal defect, which is a hole in the two top chambers of the heart where red blood and blue blood are mixing together. What I like about interventional cardiology is it combines a medical field with an internal medicine background and then specializing in cardiology and interventional cardiology beyond that. So it was very easy for me because it's almost like being a surgeon with a medical background.
Excellent. Thank you so much for being here. Let's meet our final panelist, Dr. Darren Traub, a cardiologist and electrophysiologist specializing in correcting abnormal heart rhythms. Dr. Traub completed medical school at the Philadelphia College of Osteopathic Medicine. He completed fellowships at Strong Memorial Hospital of the University of Rochester and at Western Pennsylvania Hospital in Pittsburgh. Thanks for being here, Dr. Traub.
Thank you for having me.
So what is an electrophysiologist? Tell us what you do and how did you become interested in this specific part of cardiology?
So electrophysiology is basically, as you said, the study of heart rhythm disturbances. And simply put, I'm an electrician of the heart. I love treating heart rhythm disturbances just because I always liked learning about them, and I get great satisfaction in patients whose heart rhythms are too slow or too fast, and they come to me and I can fix them and really make them feel better.
That is a great way to look at it, an electrician of the heart. Well, thank you all for telling us a little bit more about what you do and why you do it. Up next, we'll dig deeper into cardiology services available at St. Luke's. Stay tuned. We'll be back after a short break. You're watching St. Luke's Health Now.
St. Luke's has been named a top 50 cardiovascular hospital in the country for the 8th time, and we're in good company. St. Luke's has the only local heart care team to be ranked in the top 50, along with Mayo Clinic and the University of Pennsylvania. This means our heart patients have higher survival rates, fewer readmissions, fewer complications, and better patient experiences. Using the highest quality healthcare standards, no other hospital in the region has better heart care. St. Luke's, the heart care you trust.
I'm a photographer / maintenance man. I have been a photographer since high school. As for now, I love landscape photography. I've recently been more exposed to the wildlife end of it by a friend of mine. Well, I was getting knee replacement in October of 2019, had the knee replacement, and it was about 2 weeks later. Had a seizure, which my son came to the house the following morning, and I was talking very clumsily, and I was just wandering dazed through the house. And my sister, who was an RN, she said, take him right to the hospital. That's when they diagnosed me with the seizure, which had led to the diagnosis of a lung mass on my right lung. From the time I entered the emergency room that day till I was finished with treatment, I think every nurse, doctor, aide has been by my side. I met Dr. McCulloch through the radiation oncologist I was seeing. He took the time to talk to me, and I didn't feel like a patient with him. I felt like I was talking to a friend of mine. They supported me in every possible way. I trusted St. Luke's with my care because they have a very good reputation. Overall, nurses right up to the doctors.
Welcome back. Thanks for joining us tonight. I'm Ashley Russo, and this is Health Now. We want to thank our viewers for watching our program tonight and for providing us with questions for our panel, which we'll get to later in the show. Joining me is a talented panel of medical professionals, Dr. Michael McCulloch, Dr. Chris Sarnosky, and Dr. Darren Traub. We've learned about your expertise. Now we want to dig a little bit deeper into the cardiology treatments available at St. Luke's. So, Dr. McCulloch, I'll start with you. Your subspecialty is cardio-oncology, and I have to say this was a new term for me to use in prepping for this show. Can you tell us what that is, and why are certain cancer treatments more susceptible to affecting the heart?
Certain cancer therapies, for instance, radiation, if it affects the chest area and the heart area at certain doses, and certain types of chemotherapy can, in some patients, be heart toxic. Not in every patient, but in some patients occasionally. So cardio-oncology is essentially the field within cardiology that really focuses on the care of patients with cancer or a history of cancer therapies that may pose heart toxicity. And within that, we can focus on the prevention, management, and treatment of disease if they do have disease.
It's really an incredible subspecialty, especially with how many people, unfortunately, do need to go through cancer treatment.
Absolutely.
Dr. Sarnosky, when is someone referred to an interventional cardiologist from their cardiologist? Is that the progression? You'd see your cardiologist and then they get referred to you?
That does happen. So for instance, if somebody were to fail a stress test, they were having some chest discomfort or trouble breathing, they may be referred for what's called a heart catheterization, where we go into an artery in the wrist, typically the leg on occasion, and we take pictures of the heart arteries and check for blockages that may be causing the chest discomfort. So typically anything that's narrowed more than 70% or so in a big blood vessel of the major heart arteries, at times we will alleviate that obstruction by inflating a balloon and a stent, and then that stays in the patient lifelong and helps with their symptoms.
Amazing, lifelong, that's incredible. Dr. Traub, I want to ask you, as an electrophysiologist, what are some of the things that can cause the heart to fall out of natural rhythm? When you think about what you do, it does affect a lot of people, but what are the things that cause it?
That's a great question. So some people are simply born with the predisposition for a heart rhythm disturbance. Sometimes I see patients even in their teens who they're born with an extra circuit in the heart, and we can go in with catheters and actually find that area and cauterize the area and eliminate their symptoms. So that type of patient might all of a sudden have a heart rate of 200 beats a minute, and then it would go back to 60 beats a minute, and then 200, and that's called an accessory pathway. Some people have had heart attacks or have leaky valves, and they develop rhythm disturbances because of the weakening of the heart or other heart problems. And then sometimes just aging, you know, as people get older, I tell them we sort of gray on the outside and on the inside, and sometimes their hearts slow down because of that graying and they end up needing pacemakers.
A lot of reasons, so if someone suspects something, they should ask for help.
Absolutely.
All right, Dr. McCulloch, let me ask you this. Why is getting heart care and intervention during a cancer journey so important? Is that early intervention, so to speak, or to following a patient early on important, or do you wait until they're totally done?
Yeah, it's a great question. I think it's patient dependent. There are certainly certain patients that have particularly high risk factors for heart toxicity with cancer therapies that the oncologist may want them to see me before they start treatment to get additional testing or screening to make sure they're in shape to tolerate the chemotherapy or the radiation. That would be one scenario. Another scenario would be the most appropriate cancer therapy is particularly, potentially toxic to the heart. They might need closer follow-up during therapy to monitor the heart function, either with a blood test or an ultrasound of the heart called an echocardiogram. Patients may benefit just seeing a cardio-oncologist after therapy.
And is that usually guided by their oncologist as to what level of care they need with a cardio-oncologist?
Typically, it would come from the oncologist or the radiation oncologist, which is a doctor that administers radiation therapy. Those would be the two most common, but certainly I've had patients that get referred by their primary care doctor that picks up the need to see me, or even coming from the patient because they have read an article in the newspaper or seen a TV show or something like that.
All right, that's great. That's interesting. All right, Dr. Sarnosky, you have mentioned earlier the structural heart program and a structural heart condition. What is that, and how does someone know if they can be a part of it?
So simply put, the structural heart program refers to non-artery problems of the heart. So for instance, if somebody had a leaky valve, such as the mitral valve, which is very common in the adult population, we can repair the mitral valve and we can replace the aortic valve by doing catheter-based therapy. Additionally, there are some congenital structural problems with the heart, such as holes in the heart. But we can also fix that by placing a self-centering disc device to close that hole. Some other structural problems, such as Darren referred to an irregular heart rate. There is a very common irregular heart rate called atrial fibrillation, which predisposes patients to strokes. Sometimes those patients, for a variety of reasons, typically bleeding, can't be on a blood thinner to help protect them from their stroke. And there is a part of the heart called the appendage on the left side. It's sort of like the appendix of the heart. And we can plug that with a device as well so that patients can safely come off their blood thinner and protect them against stroke.
One of my patients today who I saw in follow-up, who I put a pacemaker in many years ago, developed a very tight or narrowing of his aortic valve. And Dr. Sarnosky fixed that by putting a new valve in without the patient needing surgery. So there's a lot of interaction between actually the three of us in terms of inter-referrals to patients. So we all kind of work together as a team to make sure that we're giving the patients the most up-to-date and state-of-the-art care.
Which is really what patients want to know. So thank you all, that's great information, but we're not done yet. After the break, we'll learn more about technology and new programs offered at St. Luke's. You're watching St. Luke's Health Now. Stay tuned.
Interested in a medical career? Consider St. Luke's if you want to be a doctor or a nurse. Based in Bethlehem, Pennsylvania, we are the area's only 4-year medical school and the largest provider of medical residencies and fellowships, and the country's longest-running school of nursing, trained at an organization that is nationally recognized in education, patient care, and quality. See why we are ranked the nation's #1 teaching hospital. Where you train matters. The best doctors and nurses train at the best hospitals. St. Luke's University Health Network.
My name is Paulette Shook. I'm retired from Bethlehem Steel, and we like to go antiquing, and we used to go to flea markets and walk a lot. But in 2021, I was riding the recumbent bike. I felt tired after only 5 minutes. So I put my oxygen thing on my finger, and my oxygen wasn't that bad. It was like 91 or something, but my pulse went down to 40. So when I had my appointment with my regular cardiologist, he found that my heartbeat was going down low at night, and he recommended that I get a pacemaker. I called Traub's office and I went in to see him. This new one, he says, might be just what you need. It's the Abbott leadless pacemaker. It's really a good pacemaker to have, because you don't have all those wires underneath your skin, where this is right inserted in your heart and screwed into it. So they went up my groin and put it inside my heart and attached it to the heart muscle. So I've been doing good since then, and I'm still riding the recumbent bike at home, and I do the stepper and everything, so I do get exercise. With the pacemaker, you're more confident that you have that backup. The team at St. Luke's, they listen to you, they take care of you. Everybody was really nice to me and everything, and St. Luke's is our hospital. That's one we go to all the time.
Welcome back to St. Luke's Health Now, a show dedicated to giving you the most up-to-date information on innovative medicine. I'm your host, Ashley Russo, and we have an interesting show for you tonight. We're talking innovations in heart care at St. Luke's University Health Network. In case you're just tuning in, I'm joined by 3 St. Luke's medical professionals, Dr. Michael McCulloch, Dr. Chris Sarnoski, and Dr. Darren Traub. Thank you all for being here. In the first part of the program, we learned a little bit about what each of you do and why you do it, and then we learned a little bit more about the different things you can treat at St. Luke's. But I want to talk about some of the specific technologies and advancements that you're seeing. Dr. Traub, in the beginning of the program, we were talking a little bit about arrhythmias and how people have an irregular heartbeat and need to get help for it. What if they ignored that? What are the risks that they're taking?
So some arrhythmias are completely benign, and actually when patients come to the office, I just reassure them and say, as long as it's not bothering you, don't worry about it. Atrial fibrillation, which is the most common arrhythmia that we treat, if it's ignored, it could cause a stroke. It could cause the heart to weaken. So if you have atrial fibrillation, and you may know it or you may not know it, but if it's discovered and left untreated, unfortunately the results can be catastrophic. There are other rhythm disturbances where the heart goes fast and it's just very uncomfortable, and most patients wouldn't leave it untreated just because it affects their quality of life so much. And so that's why it's important to follow up with a doctor when you have an arrhythmia. Don't just ignore it.
Yeah, there's no way for a person to know that without getting checked, so
That's
definitely
correct.
get checked. Dr. Sarnoski, I want to ask you about shockwave intravascular lithotripsy. Am I saying that correctly? Look at that. Can you tell us what that is? Those were lots of big words. What is it, and who is a candidate for this procedure?
Shockwave IVL, as we like to abbreviate it.
Oh, that's so much easier.
And it uses the technology of lithotripsy, which more commonly we think of, pulverizing kidney stones or gallstones with lithotripsy. So they were able to take that technology and put it on a balloon. So on that balloon is the lithotripsy technology. So if somebody has a very calcified blockage, which happens over time, that's why you sometimes hear hardening of the arteries, where the blockage is truly calcified, that's when lithotripsy can work and cause a microfracture of the hardened blockage, and then allow us to prepare that blockage to inflate a stent.
That's really incredible. All right, Dr. McCulloch, let me ask you this. How have cardiac imaging technologies, things like MRI and CT, improved the care of cardio-oncology patients?
We can now use CT scanners to sometimes non-invasively look at the coronary arteries. It doesn't always work. It's not the perfect test for every patient, but occasionally in a certain patient, you can exclude significant blockages in the coronary arteries with a CT scan. Cardiac MRI, we can now get very detailed pictures of the heart with an MRI. And that's very helpful in cardio-oncology because some patients do not have good echocardiogram images in the setting of getting potentially a toxic chemotherapy or that could potentially be toxic to the heart. Sometimes we need to follow the heart function with serial echocardiograms. If it's a bad echocardiogram, we don't know what the heart function is. And in the old days, we needed to get something called a MUGA, which is has a lot of radiation exposure and gives you limited information, just the pump function. Whereas we can now go to MRI, which is radiation-free, and can give us a lot more information about the heart.
Dr. Sarnoski, we are really fortunate to have some amazing life-saving innovations, including things like transcatheter mitral valve replacement and transcatheter aortic valve replacement. What are these interventions, and whom are they most appropriate for?
Sure. So transcatheter mitral valve repair involves putting a catheter in the leg vein, and putting a clip up into the mitral valve tissue. Similarly, we can do a transcatheter aortic valve replacement, full replacement, by doing the same procedure in a leg artery, where we go up and we inflate on a balloon a new valve. For anybody over the age of 65 years old who ordinarily would have an open heart operation, TAVR, transcatheter aortic valve replacement, has revolutionized that procedure, and now pretty much with the exception of younger patients, most of all those patients are getting TAVR.
What's amazing about all of this is it sounds like patient recovery time is a lot less, and the concept of needing big open surgeries is really being reduced.
Absolutely, and that's what patients really are interested in, is quick recovery times.
Absolutely. Well, speaking of quick recovery times, I want to ask you, Dr. Traub, you use something now, the leadless retrievable pacemaker. In fact, I think you were the first in the region to do this. What is that, and how is it different from a conventional pacemaker people may have seen from many years ago?
So a traditional pacemaker requires an incision to be made in either the left or right chest wall, and we make a little pocket. We put leads down to the heart, and then we put a battery pack in and close it up. And those are excellent devices, and we still use a lot of them. Battery lives are about 10 to 15 years. A leadless pacemaker, which I'm holding in my hand, and this is actually the first retrievable leadless pacemaker. You can see that it's got a little area here that you can grab onto to take it out when the battery life is expired. We deliver those through the vein in the leg. There's no incision. The procedure takes about 20 minutes, 30 minutes tops, and the batteries tend to be a bit longer. For instance, this battery life is about 15 to 20 years, believe it or not. They do have some limited patients that they're available for at this point in time, but for the right patient, it saves the patient needing a surgical incision, worrying about wound healing, and then also at the end of the battery life, we can take them out and replace it with a new one.
It is really incredible to hear all of these advancements in cardiology happening right here at St. Luke's. Thank you for this information. Up next, we're going to get questions from our viewers, so stick with us. You're watching St. Luke's Health Now.
St. Luke's has been a cornerstone of the Lehigh Valley for over 150 years. It was originally founded to provide industrial workers with immediate local access to care. In the last century and a half, while healthcare has transformed dramatically, St. Luke's dedicated physicians, employees, and volunteers have proven they can respond to changes with exciting, innovative, and bold healthcare solutions. St. Luke's ability to deliver the highest quality care at the lowest cost is truly transformational and will ensure our future.
Welcome back to St. Luke's Health Now. I'm your host, Ashley Russo. A special thank you to our outstanding panelists. We've had a great conversation about innovations in heart care at St. Luke's University Health Network. Now we're going to read some questions from our viewers. You guys ready? Yes. Okay. This first viewer writes, I am 65 years old and recently diagnosed with breast cancer. I've had surgery to remove the tumor, but will be starting soon on a course of radiation therapy. My heart is in good shape. At what point during my treatment should I see a cardio-oncologist?
They're asking about radiation, and one thing to know is it actually affects the heart differently whether it's left or right-sided breast cancer. So left-sided breast cancer treated with radiation can potentially affect the heart slightly and slightly increase the risk for cardiovascular disease. Again, it's pretty minor in the setting of breast cancer therapy. The right side, on the other hand, typically has no exposure to the heart in terms of radiation therapy, which therefore would not increase their risk at all. It might depend on their other cardiac risk factors and whether or not they had any chemotherapy treatment that may have potentially affected the heart. And then bringing all that information together, they may need to see the cardio-oncologist, before therapy, during therapy, after therapy, or potentially not at all. And they could discuss that with their oncologist or their family doctor, and they could reach out to cardiology or cardio-oncology if they have any questions.
Dr. Traub, I believe this question is for you. My 82-year-old mother was just diagnosed with atrial fibrillation. What type of heart care do you recommend for a person of this age? Is she at greater risk to let it go without treatment, or do you recommend an intervention to normalize her heart rhythm? This is probably pretty common. People in their late 70s, 80s, even 90s, and the children wondering, should they bother getting it treated?
That's a very common question, and the average age of a patient with atrial fibrillation in our country is 75, so as the baby boomers get older, we're starting to see more and more atrial fibrillation. But the answer is absolutely she should not ignore it. She should be seen by a cardiologist. The first thing that I always tell patients is that we need to prevent a stroke from happening. So if she's appropriate, she should be treated with a blood thinner, and there's a variety of options for that. If she can't tolerate the blood thinner, she could see somebody like Dr. Sarnosky for a Watchman, which also helps prevent strokes. And then finally, whether you make an effort to restore regular rhythm or not depends on the patient's symptoms. If the patient's heart rate is maintained between 60 and 100 beats a minute and they have no symptoms, there's no reason to restore regular rhythm, which can involve something as simple as a cardioversion or medications or an ablation. If they have symptoms related to their atrial fibrillation, then we certainly should consider restoring regular rhythm.
Okay, Dr. Sarnosky, I think this one is for you. This viewer writes, my husband's doctor just recommended he have TAVR to replace a tight heart valve. Is this a less risky procedure than having open heart surgery? And what is the recovery time? I bet people want to know that all the time, right? What is the recovery time and what are the risks?
Well, thankfully, in 2023, patients over the age of 65 are now getting for a tight aortic valve TAVR. So when that valve gets replaced, well, it's through a small tube. In some places, they can go home the next day. Typically, our experience is they're usually home in 24 to 48 hours with no incision.
Okay, I'm not sure who this is for, but you guys can jump in. I see a cardiologist to manage my angina and take statin medication for high cholesterol. I also receive chemotherapy to fight my leukemia. What can I do to take the best care of my heart while I undergo cancer treatment?
If they're being followed by a cardiologist, so the first thing would be just to make sure their cardiologist knows that they're being treated for the leukemia and that all their cardiology conditions are optimized as best they can. And then the other thing would be to talk to the oncologist and make sure that they know the heart disease that the patient has. Because occasionally, if a patient has certain heart disease, it might influence the decision for what type of chemotherapy to use or what dose to max out on. Not common, but occasionally that happens. So just make sure the oncologist knows that they have the heart history and reviews it, and then reach out to their cardiologist or cardio-oncologist if there's any questions about that.
And the angina portion of that question typically is the medical term for discomfort coming from a blocked heart artery. So if a patient were to exert themselves at a high level, such as climb up a few flights of stairs, they might feel a tightness from a blockage in the heart. And statins and a variety of medications are available to help with that. But also we want to make sure that they're not missing something. For instance, a blockage in one of the main heart arteries, where we can go in and help with those symptoms by inflating a balloon and placing a stent.
All right, excellent. I think we have time for one more question. My dad had a cardiac pacemaker implanted 10 years ago. How long do these devices last? He's 78 now. Is it possible he'll need another one implanted during his lifetime?
Well, the good news for your father is that pacemakers last 10 to 15 years. And if he's in good health, he probably will need a battery replacement or generator replacement. So I tell my patients who are getting pacemakers, average battery life is 10 to 15 years. Some of that depends on how often they use the pacemaker. Do they use it 100% of the time or 50% of the time? But the reality is most patients, if they're going to live into their 80s and 90s, will need a battery replacement at some point in time. And that's just a small incision. We take the old one out and put a new one in. It takes like 20 minutes.
And as you mentioned, that's good news because you're here to need another one. So thank you all for this information. I find this an incredibly positive and uplifting program because there are so many amazing interventions as long as people go and see their doctor at St. Luke's. Thanks for joining us.
Thank you.
For more information on heart care at St. Luke's University Health Network, please visit their website at sluhn.org or call 1-866-ST. Luke's. I'm Ashley Russo. This is St. Luke's Health Now. Thanks for tuning in. Until next time, be well and remember it's important to focus on your health now.